Good afternoon, everyone, and thank you for being here today with us at the kickoff session of the Vitrolife Group Academy Studio. My name is Nasser Al-Asmar, and I am the Scientific Director of the Genomics Academy. Today, it is my pleasure to introduce you my colleague and friend, Tiffany Stankiewicz, who is going to be hosting the first session that is going to talk about the endometrial, meeting the experts, two key opinion leaders, not only in the US, but worldwide. So, Tiffany, please, whenever you want.
Thank you, Nasser. So thank you, Dr. Amy and Dr. Rogers, for being here today. I'm super excited, especially to kick off with you two. We had a webinar back in March, and it was really well received, so we're super happy to do an encore today. And, as the title said, we're talking about endometrial analysis. So we know it plays an important role in IVF treatment for patients that optimize outcomes, receptivity, microbiome. So we're just having a nice casual conversation about endometrial testing today. We are live here at ASRM, and we have people walking back and forth the booth. So if there's any questions out in the crowd, feel free to raise your hand and we can discuss it. But I think I want to start today maybe talking about a little bit of a hot topic, which is endometrial receptivity analysis. So we've been hearing a lot about that, whether it's good or bad. But there's been some publications showing, no benefit, but in the good prognosis patients. And I think it's important when we have such personalized tests like endometrial receptivity that we're using it in the indicated population. And I'm just interested to know, how are you using receptivity analysis in your own practice, and in which patients, and maybe give us your opinion on some of the publications that have come out recently. So whoever wants to start.
Maybe I will start. So I think that these studies were really important to help us understand and get a little bit more clarity about data in what populations this test is best for. And, I think we were all a little surprised by the data, maybe, that there was, like, in the general population, maybe a higher chance of pregnancy, right? But I still think that there is a very real and necessary population that really benefits from endometrial testing. And personally, I like to use this test in people who failed a PGT-tested embryo. So if you put in a PGT-tested embryo, and I understand the success rates aren't 100%, but really we should be looking for other things, whether it's, issues structurally inside the uterus, whether it's microbiome issues, whether it's receptivity issues. I think those are some really that's an important group of people who I recommend ERA for. And certainly the other population I still offer to is people with very, very limited embryos, right? Like, I understand recurrent implantation failure. You need to be able to have enough embryos to have recurrent failure. And if you don't have enough embryos, it's something that I offer from the beginning.
And I'm all about little sayings like the egg whisperer diet. And I've learned one saying from her, and I actually channel you all the time. And it's diagnosis, prognosis, and treatment, right? So what are we doing, and why are we doing it? What are your chances, and what are your options? And that T, treatment options, I think it's really important for us to leave no stone unturned and to offer a patient the menu of options for her to choose from, and we're not choosing for her. So for some patients, for example, I could have a patient that has 10 euploid embryos, and she just really wants to do the test because she wants to leave no stone unturned. And then I have the patient who has, let's say, one normal embryo, and she just doesn't feel like she wants to do the test. But if she does not have a successful transfer, at least she was offered it.
Yep.
So that she can't say that she has regret. So we can honestly say we thought about all the options and we made the decision for the choice that was best for us at the time.
And I think that's important, because I think you're probably seeing this trend in your own clinics. Like, we're welcoming a new generation of IVF patients with Gen Z, and they're really well educated on everything they do. I mean, social media has been like a huge catapult for them to learn about any part of their lives. Right. So these patients are coming in well informed, and they want to know the options, because they also want autonomy in their care. They want to feel like they're a part of their care, not being told this is what they should do, but being guided of what the options are. So I think, this new generation, we need to kind of change the practice and consider that. So.
Yeah, I mean, I think the one thing that can be really frustrating for a patient out there is that they go to a physician that says that they don't believe in it and it's junk science and you're wasting your time. And I would argue that my implantation rate is almost 80% for those who do the test. So in my hands and in Dr. Rogers' hands, with me performing the test, following a certain protocol and making sure that it's followed perfectly, and I monitor levels before and after. So I feel like in my hands, the test actually performs really well. And maybe in another clinic when there's a whole bunch of doctors and maybe people are just missing important pieces for that, that one big puzzle that they have to put together at the end to design the most beautiful transfer protocol. Maybe they're just missing some of those important pieces and, sometimes starting things a little too late, too early, and not paying attention to the details.
Yeah, exactly. I mean, protocol compliance is absolutely necessary when it comes to ERA because it's such a biologically dependent test. It's not PGTA where we simply get euploid or, abnormal, or we have mosaicism, but it's not as clear as to what we need to do with ERA because we have to depend on, when does progesterone start? Because that's going to affect the reproducibility. So super important. I know that both of you performed the test well and you've been very successful. I've been working with Dr. Rogers for a long time with her cases. And Dr. Amy, you just looked at your clinical outcome, and like you said, you have an 80% implantation rate, which is something that we encourage clinics to do. We have a scientific advisor team who can come out, look at your clinical data, because we also know that we don't always have time to put in all of that and to understand how the test is performing in your hands. But we definitely do see differences between clinics and their outcomes.
Can I ask you a question about your data?
Yeah.
Was that data with natural cycle, stimulated,
modified natural,
and
letrozole with estrase only, different types of estradiol, Vivel
and you just
patch,
took all of your ERA cycles?
All of them.
That's phenomenal.
Some did Lupron.
80%.
Some did Lupron first.
Wow.
Yeah.
Congratulations.
Suppression for 1 to 2 months.
That's amazing. Right? Yeah, I do with some of that.
Yeah.
Yeah, and it's especially for patients where we're reserving this test a lot of times for recurrent implantation failure. These patients have exhausted a lot of other options, and we just want to optimize things as much as possible because as easy as to say, well, just try again, a lot of patients can't just try again, whether it's financially, psychologically. I mean, the strain on their relationships with their partners, that all needs to go into consideration.
Yeah. Well, and the other thing is, why would you try again something that didn't work?
Right.
Yeah,
Why
I think
would
that's
you continue
insanity,
doing
right?
something that's not working? I know I always am trying to, if something didn't work, let's not do the, and maybe it was the embryo, but if it's a PGT tested embryo, why are you doing the same thing that didn't work?
We should call it PRIF, prevent recurrent implantation failure.
I love your
I love that.
acronyms. They're
That's
amazing.
why I say I call it the prevent recurrent pregnancy loss workup. So before you even have a loss, let's see what we can do to even prevent it. If you've had even one, I do, and I'm sure you do too. And that's part of this process is preventing those worst case scenarios that you don't want to live through with patients because we're so emotionally invested.
Yep.
Yeah.
Can I ask you a question just from the iGenomics side? I know that we can run the ERA test in a natural cycle.
Yes.
And I know we can run the test in a hormone replacement cycle. What are the thoughts these days on stimulated cycles, either like a letrozole?
So with stimulated cycles, obviously, we have super physiological hormones, and that can affect the reproducibility of the results.
Well, maybe not with letrozole, I guess.
But we're like with gonadotropins
Yep,
if we have
absolutely.
ovarian stimulation. So, we want to ensure as much reproducibility as possible, and that's why we've always said, okay, HRT is going to be your way to go. But natural is certainly acceptable too.
And it just takes a lot more hand-holding.
Yep.
And that's
And
the
maybe
thing.
close
more
monitoring.
visits, more ultrasounds, more blood draws, and that's okay for me because I don't want patients putting stuff in there.
I love natural cycles. I do. I love natural cycles. I mean, I do.
How
Hormone
funny.
replacement cycles are great for a lot of reasons, and they're super reproducible. I think that it's nice because patients can schedule exactly when it works for them. I know I'm going to be there, but
Oh, yeah.
natural cycles are fantastic. For the right patients, of course.
Oh, of course. Absolutely.
And I think we're seeing a trend with that in general with natural cycles, and that's globally. We've been getting more questions about natural cycles. Can we use ERA? Of course, you can use ERA. That's where it was validated in natural cycles. but there's a lot of data showing that the natural cycles have really good outcomes.
Very good outcomes. And
Absolutely.
that's why one of the reasons. And I think that truly, like, I mean, we see these patients on these journeys, and a lot of times by the time they get to a transfer, even if it's their first transfer, right? Maybe they've tried on their own for a long time, then they did something with their OB for a long time, then they did like whatever, Clomid, letrozole, IUI, IVF, and they did a whole IVF stimulation. And so like by the time they get to transfer, sometimes they're just ready for
They're
like
tired. They just want to move
less
forward.
meds, more natural, like
Yeah.
kind of back off a little.
Well, and I'm also curious to see, like, as we said earlier, with the new generation coming in, like we've seen a trend of like Gen Z, like going off birth control and trying more natural methods. So they're much more concerned what's going into their bodies. And I just wonder if this is going to be a trend just relating to the generation coming through now.
Right.
So it's exciting. I mean, I think that's the thing with IVF. We can't just keep doing the same thing that we've been doing. We have to progress.
Right.
And I think we're going there. So personalized medicine is key, not only in IVF,
Absolutely.
but everywhere else. I mean, we were talking the other day about the microbiome and how important that is, especially at the endometrium, let alone the rest of our body. And I'm just curious, is this something that you're looking a lot in your own practice, or where do you think that's playing a role in endometrial health, or we know in endometrial health, I think there's big things coming with the endometrium. With the recent study about endometriosis and fusobacterium in the endometrium, the potential there.
Yeah.
But in reproduction, we know that, for years, that pathogenic bacteria in the endometrium can lead to poor outcomes. We see it in chronic endometritis. So I'm just curious what you are doing in your own practice regarding microbiome.
Yeah, you want to take this one first?
Well, I mean, as soon as the Trio test became available, I started adding it on. So it didn't make any sense to me. If you're doing ERA, why not just check another box and do the M and Alice? And I'm just heartbroken for those patients out there who have recurrent implantation issues. No one's a failure in my eyes. Just want you to know that.
I love that.
I don't ever use that word in my practice. It's very triggering for me because my mom said I was never good enough. I'm just kidding.
Oh my God, you're poor
We're going
mom.
deep today.
So, welcome to my therapy session, everyone. Hi. But my point is that I had a patient had 2 failed transfers. Like, she had tubal factor. Her embryos were gorgeous. And I'm like, this just makes no sense. I had already done ERA on her. And then you guys came out with the M and Alice, and I'm like, I don't, like, what else? I've already done all my other voodoo hocus pocus stuff. And I'm like, I'm going to do this. And she had like 3 or 4 things light up.
Yeah.
And I was like, this is bonkers. Treated it, next transfer,
Pregnant.
and she
love
was
it.
like ready to
That's
give
amazing.
up, like you said, strain on the marriage, on the relationship, and like her friend group, and then she had a baby.
I really feel like as fertility doctors, we are problem solvers and not always easy problems, right?
Yeah.
Right? So I
Not
feel
always
like,
the same problem.
oh yeah, no, so think about it. Like most people get pregnant without our help. Great. We're like, we're already dealing with this patient population who are either with the new definition of infertility, not being able to have a successful pregnancy or not being able to get pregnant, right? And so we're taking this group that's already in this, 15% of the population, and we're having to like figure out what to do with them. And when sort of regular IUIs work or regular IVF cycle doesn't work, this is where like really digging deep and trying to figure out, why is this not working? There's only so much science we have at our fingertips, right? And there's still a certain percentage of patients who we can't figure it out. But I think this is an amazing tool because I absolutely have had patients who should have gotten pregnant like multiple times over with euploid embryos and they're not. And then you do a test like this and not only receptivity, but the Alice and Emma testing, if all it is antibiotics. The thing that I really was shocked about when this test came out, and it's been a couple of years now, right?
Yeah.
2021.
Yep.
One of the things that I was most shocked at is I think that when I was getting regular biopsies back with CD138 and they were coming back positive for chronic endometritis, I typically, like, my go-to is the regular gynecologic antibiotics. Z-Pak, Doxy, cool. The percentage of bacteria that was coming up on this test that was not covered by those 2 drugs, which are the like go-to standards, was so high that I was like probably mistreating so many patients, but we didn't have anything, right? And so now being able to target what bacteria, what antibiotic, And I would love for you to, talk about some of the newer resistant strain testing and stuff like that. I mean, that's like fantastic. This really allows us to be able to accurately treat patients and improve pregnancy rates.
No, and it's true. We know that, we talked about this the other night, there's a staggering statistic by 2050, as many people will die because of antibiotic-resistant bacteria as cancer. So it's
crazy.
It blows my mind. And I've told everyone the statistic because I believe in like responsible antibiotic use. I mean, antibiotics, I'm not obviously against antibiotics. They're one of our biggest tools we have in modern day medicine, but we have to use it properly because they can be really powerful, but when it's used improperly, it can hurt us. And that is the advantage with a molecular platform like Emma and Alice, because it's an objective test where we can see, okay, which bacteria are actually present in the endometrium. And now, so actually starting next month, we've been doing this globally, but in the US, we'll now have the actual antibiotic recommendation put in the result. So we'll say amoxicillin, this many, the dosage 7 days or whatever. So it's a more direct recommendation. So there's no guessing like, okay, here's the bacteria, let me find what antibiotic, and then go over here and figure out the dosage. It's going to be right on the report.
Yeah.
So we're hoping that'll improve clinical outcomes further, because just like the ERA, sometimes that's missed with the targeted approach.
Right.
So super excited about that.
Right.
Me too.
Yeah.
So I don't know if Dr. Amy, with the microbiome, you said you've been using it as soon as ERA comes out.
As soon as it comes out, 100% of patients do it. And I just don't understand. If you're putting patients through a biopsy and you're getting like plasma cells, like it's the same freaking procedure.
Mm-hmm.
You just put some of the cells in another tube and you can give patients more information.
Yeah.
Yeah, and a lot of times are you doing both of them at the same time?
So for some patients I am.
Uh-huh.
I certainly have another group of patients who, who have maybe had failed implantation, have maybe have untested embryos, maybe not quite as clear, and I'm doing a hysteroscopy on them. A lot of times, while they're on birth control for their hysteroscopy, and while they're asleep, I will do an Alice Emma test along with the regular pathology. And because I'm sure you notice, you do a hysteroscopy on someone and then maybe there's some polyps, and you do the sample, and I always have them stain for CD138. I feel like there's always some plasma cells, especially in the setting of polyps. And then the question is well, and I always ask this question, right? Like, is that infectious? Is that just inflammation from the polyps? And when you have the ability to do Alice Emma testing, or just Alice alone, even for patients, I mean, I think, that is something that is a very easy test you can do while someone's on birth control. They're asleep anyway. So I love doing that. And maybe someone who's not quite ready for a whole ERA cycle.
Yeah.
Right.
Because if you're there anyway, it's just like you said, they're asleep, you're doing the biopsy anyway, you might as well.
And there are patients who aren't ready for IVF and they just want to learn more about their uterine environment, and I'll have them come in for the test as well because they're just curious.
Yeah, and it could be something simple as a pathogenic bacteria that's persisting,
Exactly.
leading to the failed implantation.
Right.
Because we know, especially those difficult ones like Gardnerellas, Streptococcus, Staphylococcus, they're associated with a lot higher or poorer clinical outcome rates.
Mm-hmm.
So it's interesting to think that maybe we can save some patients from undergoing IVF that would just be treated with antibiotic. I mean, we were discussing this morning, they're using antibiotics in targeted therapy in cases like with autism, where they found that the symptoms go away with certain antibiotics, that it could be in some cases bacteria induced. And I think when it comes to microbiome, we're going to see this a lot in just general medicine and specifically in reproduction. Even here, walking around ASRM, I saw a couple of booths. It's like how to optimize your microbiome for reproduction, or optimize your diet, which obviously is going to affect your microbiome. So it's, I think, again, we're heading more towards personalization, and this is just one key aspect of it.
Right.
I don't know if we have some people in the audience, if we have any questions. If anyone wants to ask, don't be shy. So I don't know how much time we have.
I think David was going to ask a question about our favorite probiotic. Right,
Oh,
David?
Yeah.
Yeah. Do you have a favorite?
I really struggle. In fact, Amy, we need to put together a product.
100%.
I'm like, I want to create a vaginal probiotic for fertility. So the hard part about vaginal probiotics is that there are so many vaginal probiotics out there that are for recurrent, like bacterial vaginosis, for recurrent yeast infections, and they have a lot of other stuff in it, like boric acid and other things that we don't really want our embryo transfer patients maybe taking. And I also worry about like some of the compounded medicine, right? Like we were talking about the other day, like compounded medication. Well, like that's live bacteria. Is the bacteria alive after it's been like compounded and like melted into like a little, wet wax, or suppository? Or is the bacteria even alive and doing anything, or have we killed it because with heat or something? I would be really curious to. So this is one of my goals. Is to do some like product development.
Mine are sex toys.
Oh, okay. That's a little not appropriate.
Oh.
I mean,
yes.
When I'm way older, like Dr. Ruth.
So
that's a
how long has the course of antibiotics take per patient? So our recommendations, the max is 7 days. But of course, we're a genetics lab. We're not physicians.
I usually do 7 to 10. Like if you look at like treating endometritis, like active endometritis, like it's 7 to 10 days. So I like, as much as I don't want patients on antibiotics any longer, I think that some antibiotics and some infections that might not have as much blood flow and blood supply, right? We're thinking about like inside the endometrium as opposed to like, maybe as opposed to like the myometrium, which might have better blood supply, but clearly there's not a ton of data on how long people need to be on exactly what treats it.
Well, I've been offering a lot of patients a second biopsy. I don't know if you started doing that.
Before antibiotics?
After. So I'll treat them, and then it's depending on the case. I mean, if this is a patient who's worked her butt off for 6 cycles, 1 euploid, and we find something, then I'll do a second biopsy. And I've had the case where like something else comes up, and it's like, then I start thinking, do you do partner testing?
No, but we were talking about this the other day, right? Like whether it makes sense.
Other exposures to avoid, like what I just talked about.
Yeah. So, well, right. So,
Literally.
like, so the question is, do you recommend protected intercourse then?
Yeah,
If
I mean,
people have
for those
persistent
types of cases,
chronic endometritis, if they're getting it sexually.
We get that question a lot. Should we treat the male partner? Should they avoid intercourse? And we don't know where the source is coming in each patient. It come from just diet, hygiene. If they're on antibiotic use, maybe they had a dental procedure. We don't know what's happening.
Right.
But I think it is a good idea to be a little extra cautious before before implantation, because we want to ensure an optimal microbiome for that implanting embryo. But the case of the test of cure, anytime we recommend an antibiotic because there's a pathogen present, it's a good idea, especially when we have those complex profiles where maybe a couple bacteria are present. But the other thing is, like you said, maybe something else will pop up new. When we're clearing one pathogen now, then the other pathogen, we think of it as an ecosystem, like, oh, I don't have any competition now. Now I can grow.
Well, the other thing to think about too is that, endometrial biopsies are very accurate and they're very good tools to do a biopsy in a outpatient setting that's pretty minimally invasive. But like when I do my Alice Emma testing at time of hysteroscopy, I do it first and then I do the scope because I don't know like the saline and who knows. So I always do it first. And when I go in and after I've done the biopsy and then I go look, and it can be certainly a very thorough biopsy when someone's asleep, right? And you can see not every single corner of the endometrium is biopsied, and that's okay. Right. But you could imagine maybe there's different bacteria in different places that just maybe haven't reached that above that threshold to make it, pop up.
Right.
And I think, you bring up thresholds. I think that's important too, because the endometrial microbiome doesn't have to be completely absent of pathogens. We actually have reference ranges within our report itself.
I can't not treat it though. I don't know. Like if you had a pathogenic bacteria that was like below the reference range,
I'll talk to the patient about it and
same.
offer treatment.
I don't think I cannot. Like I'm like these bacteria are not really supposed to be in here.
Yeah. So you want them gone?
Yeah, gone.
Yeah, but I don't think that's a bad thing, right?
I know they're below the reference range. But like, let's say the reference range is like 3.5 or whatever it is.
It's like
You're at
3.49.
Right?
Yeah.
And then, but maybe even if it's at 2.5, like it maybe shouldn't be in there. Maybe
Yeah.
that's the cause.
Yeah.
Well, yeah,
I
and
still treat it.
Yeah. Same.
yeah, and that's why we leave it to discretion of the physicians, because you guys are the physicians, not us. So we'll get that question too.
But you're right, it's a conversation.
Yeah.
Yeah.
And luckily, like, I
Most
mean,
people would say.
antibiotics in general are not real expensive. They're,
Yeah.
they're real safe. And while there are some risks, it's relatively low.
Well, and the good thing too, it doesn't really add on extra time to the patient's treatment, because a lot of times you get your results, maybe the patient started day 1, you can give the antibiotics early in the cycle that you're planning to do the rebiopsy, or even, if
Can you
you
though, like, how
transfer.
long does it, because we're looking at bacterial DNA, right? How long, if that
We
bacterial
discussed
DNA
this,
is,
you wanted,
right?
you kind of wanted to shed, and
I
you
usually
want to
like
get
to
that
have them
bacterial
like have a
DNA.
cycle, like bleed the
Get it all
bacteria
out.
out, and then with the next cycle, because I think
I'll put them on birth control pills for like 14 days.
And
And
then-
then do the second biopsy at that point.
We've been hearing that a lot with the birth control pills.
So they
That's
don't
another
have
nice
to
thing.
wait a
With
whole other cycle.
with Emma and Alice,
Yeah.
you can do the birth control pills in the cycle. So which
Yeah.
is you can't do with ERA, obviously.
Right.
But for retesting, the
Yeah.
birth control pill, and again, another affordable option for patients.
Yeah.
Right.
The only thing that I struggle a little bit with birth control pills, and I do it all the time still, is just that the lining doesn't get as thick.
Right.
So like, I really like to see when you draw the pipette out, I
See a
usually like to see a
nice,
lice,
healthy sample.
like 7 to 8 centimeters
Yeah.
of tissue.
Yeah.
I don't know what you usually give.
Yeah.
7 to 8 centimeters of tissue is what I hope for. And then if I'm putting some into another sample for like
Yeah.
regular path or whatever, even more. And when people are on birth control, I have to sort of
It's a little bit.
stay there a little longer to get more sample out.
Yeah.
So, but I mean, I think it's very convenient for patients.
Yeah, at least there's options.
Right.
Yeah.
Right. Right.
So you have another question? Oh, we have a question. Go ahead.
Yes. Is it recommended to test again after you've treated? After you've already been treated?
I think we were able to, talk about that with, especially like Dr. Amy said, sometimes a new bacteria pops up. So
Yeah. One of the questions that I have, and I feel like this is something of like new data that we need to like look at, is how much cycle to cycle variability do most people have in their microbiome, right? So, I mean, obviously pathogenic bacteria is different than, like lactobacillus, that is this like healthy bacteria. But, the question is like, if I'm doing an Alice now, and maybe someone takes a break or whatever, or we put them on Lupron or whatever it may be, in 3 months from now, if they have a healthy endometrium with normal Alice and Emma, do we think that in 3 months it's going to be similar? I'm interested in some of like this longer term data that we just don't have yet.
yeah, and with the microbiome, because it's so transient and it can be affected by so many things, like we don't know, like maybe in one person, the results are consistent 6 months later. Maybe in another person, because they had a surgery or
Or they have PCOS or endometriosis.
yeah,
or both.
it could be affecting their microbiome. So, for that reason, we always say, okay, if a patient's planning to come through transfer in January,
Right.
don't do Emma and Alice today. Wait till December.
Right.
Well,
So I
probably
tell patients 3 months before. So if you want to do a transfer, especially for baby number 2, reach out to me 3 months before, and we'll start planning things. What our transfer prep will look like, the saline
That's
sono.
perfect.
We'll review, if we did the trio before, do we want to repeat that again? And we have time to do it. So they stay on their timeline.
yeah. No, I think that's
Yeah.
perfect. Well, I guess we're getting the cue to wrap it up. I wish we can keep talking, because
We
I
could talk
really enjoy
forever.
our conversations and the
Thank
insight you
for
guys
having
have.
me.
So
Thank you for all you're doing.
thanks for making this happen. We talked back in March, and we're like, it would be a great idea to do this at ASRM. So I'm so
all
happy
there,
we
in
made
person.
it happen. So I would love to make this a tradition.
Yeah, I think so.
And I don't know if I have patients who come to me because their doctors won't do this test.
Yes.
And I'll do it for them and then guide them. And that's okay too. It's like seeing an acupuncturist for fertility guidance. You're not cheating on your doctor. It's not a love affair.
Well, I think that you got to advocate for yourself.
Exactly.
Well, thank you so much, and I'm happy that we all got together to kick off our Academy booth session. So thanks for
having
joining
us.
in.